there are certain anatomical factors that encourage urinary tract infection. Let us say these go under the heading of risk factors, and say a shorter urethra in a female, right? And that urethral aperture is quite close to the anus, unlike in the case of male, and so there is always a risk of fecal contamination. The next thing is about incomplete bladder emptying. We often see this in association with enlarged prostate and post-prostatic residual volume, post-void residual volume, right? And if so, if you have a post-void residual volume, that tends to get infected and results finally in a persistent urinary tract infection. And if you have certain congenital defects like urethral diverticulum, quite often in female urethra and not suspected during any routine examination, that will result in recurrent UTIs. Why? Because during the passage of urine, urine tends to go up into these diverticuli and stay there and finally get infected. And if you have any other structural abnormalities, that also, for example, the common conditions would be, for instance, a PUJ obstruction or a kidney with congenital malformations of any kind is prone to more infections. What are the different types of urinary tract infections? We are able to divide the urinary tract into an upper tract and lower tract. Lower tract means bladder, urethra, and lower part of the ureter, lower 1/3 of the ureter, and upper tract would be kidney and the remaining part of the urethra, right? So if you have lower tract infections, there are certain symptoms which characterize this part of infections. That is, if you have cystitis or urethritis, the symptoms commonly are dysuria, frequency, and urgency. They are usually localized and rarely cause systemic symptoms. That means it's very unlikely, although it can happen occasionally, that from cystitis or urethritis you have systemic symptoms. On the other hand, if you have infections which involve the kidneys and it results in pyelonephritis, then that quite often is symptomatic in terms of systemic symptoms, like fever will also be there, in addition to the local symptoms like renal ankle tenderness, flank pain and fever, and sometimes nausea and vomiting, right? The sign will be a renal ankle tenderness. So when you have this situation, that goes into a complicated urinary tract infection. But what is of great concern to the practicing surgeons and physicians would be the recurrent UTI. Now, there are multiple episodes classically in such a situation, and despite many long-term management strategies and preventive strategies, these infections take place. Then you have a major problem on hand because you have infections which are more than 2 or more urinary tract infections within 6 months, or 3 or more infections within a year. So these will obviously require a long-term approach to the treating, and also will require a good search for any factors which we talked about earlier, or any defects that are producing this kind of infections. And in case of complicated urinary tract infections, you will definitely need specialized diagnostic procedures and also the therapeutic approaches, right? So remember these definitions while you are going through the remaining part of the lecture. What will be the causes and risk factors? Let's look at some of them. Of course, the list cannot be comprehensive, but largely the ones which are most important. There we will look at those. Obviously, the organisms I have been mentioning right from the beginning, Escherichia coli is the most common with 85% incidence. And Klebsiella proteus, we often see these in the surgical wards, Klebsiella and proteus, and occasionally Enterococcus and Staphylococcus saprophyticus, right? The distribution varies depending upon the demographies, and it in fact varies even depending upon which wards the patients are in. Quite often we find the variation. and if you have any cause for forming biofilms. Now, I'd like to say a few words about a biofilm. What is a biofilm? It's a structured community of microorganisms. So that means in any a tube, for instance, a catheter, or even in a liquid and a solid, you can have a situation where a certain community of organisms will kind of encapsulate themselves with a matrix. That means they are protecting themselves from action by any kind of external threat. That means like antibiotics, like any kind of external threat, they protect themselves. And also the host immune system, and this is the worst part, and the host immune system as well. These are called biofilms. They can form on any surface. And for us, the common experience in surgical wards is when the patient is catheterized and the patient has associated infection, catheter associated infection. Quite often, we find that the bladder urine does become sterile because of our treatment, but within the catheter itself, there are biofilms. And they function like organized cities for microscopic life. This we should be aware of. Because after giving appropriate treatment, if you do not change the catheter staying in for a very long time are a major source of infection. In fact, if you put the catheter once, even that can cause UTIs. And the catheter staying longer than 6 hours can definitely cause infections. So, therefore, whenever you put a catheter, it should be done in the best possible aseptic environment, number one. And number two, it should not be kept for long. Once your job is over, you should take it out. If for any reason you have to keep it for a longer time, as it often happens in surgical sites, in that case, you should be conscious of biofilms, and bacteria will be there, but they won't be symptoms. These are very common problems in the wards. There will be bacteriuria, but the patient will have no symptoms. And this bacteriuria may be originating from the catheter-associated biofilms rather than from the bladder urine itself. So this, please remember the biofilm.